Hello everyone, my name's Jane Dennis and I'm the lecturer in charge at the Strathfield campus for our SWTP632 unit on social policy. So it's my great pleasure to bring the lecture to you on health policy and mental health policy this week. Before we progress, I would like to make an acknowledgement of country and acknowledge elders past and present and emerging, and particularly acknowledge the Wangal peoples in Strathfield and the Ngunnawal peoples in Canberra. And I'm speaking to you today from Watamatical country, where I'm recording this lecture. Okay, a lot to cover today. I'm going to provide this lecture in two parts. Part A, I'll be looking at how we understand health and give you a bit of an overview about health policy, and particularly the different funding arrangements that are in place, very complex system that we have in Australia. And part B, I'll be looking at mental health policy and moving on to consider health policy in the area of chronic health conditions, and finish with a bit of a reflection really about how social work might think critically in this area of health policy. So that's the plan, big plan. Okay, much to cover. So while we're going through the content, I'd like you to consider some of these questions. Just how do we define health? What is a health issue? And how does the Australian medical system define these terms? What does it mean to health practitioners? What does it mean to healthcare service users? What do you think about the two-tiered medical system that we have in Australia, that we have a public and a private system? What are your thoughts about that? How should healthcare services address mental health? Very big question. We would also encourage you to consider policy responses to acute health issues as opposed to chronic health conditions. What might some of the differences be, the different demands and impact of policy on people with different health conditions? And then further to that, we would be encouraging you to think about what social workers can do in this space to support and advocate for those who may live with chronic or complex health conditions. So to begin with, part A, we will be looking at health policy and the funding arrangements. So how do you define health? The World Health Organization, way back in 1946, defined health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So, infirmity meaning illness. So when we think about health, it's certainly much bigger than just whether a person has a health condition or not. And I've put this statement, I've drawn this from the Australian Institute of Health and Welfare, excellent source on material regarding health policy and health funding. So I encourage you to have a look at that. And the Australian Institute of Health and Welfare state that health influences and is influenced by how we feel and how we interact with the whole world around us. And it's broader than, as I say, just the presence or absence of disease. And it reflects complex interactions with who you are and how you were born and your lifestyle and environment, many things. And that generally speaking, a person's health depends on determinants, factors that influence health, and on intervention, so actions that might be taken to improve health and the resources required for those interventions. So all of these determinants can strengthen or undermine the health of individuals and communities. So we need to think about health more broadly. And of course, this statement, as you would realise, and this statement acknowledges that health outcomes and experiences of health are not the same for everyone. And all of that is often shaped by the distribution of wealth and resources at a national and local levels. And so all of the factors, including our income, our education, systems of social support or the lack thereof, all of these social determinants of health, they're known contributors to health inequalities across population groups. Okay. So there are different ways of defining health or thinking about health. And the traditional biomedical approach sees the human body a bit like a machine that sometimes might break down in some way and might need to be fixed. So under that approach, health policy becomes largely about individualistic curative interventions within the health sector. When thinking about public health or population health, there are a couple of different views, and they've evolved over time. One perspective that might be referred to as old public health, which doesn't mean that it's no longer useful. It's a more traditional view, but still very important. That views health with more of a preventative view, and it focuses on a lot of measures to protect and promote the health of communities and populations. And there are some examples there that you can see, like food safety regulations, immunisation, for example. And then in more recent times, public health has evolved to very strongly consider the social determinants of health and to look towards involving communities in identifying what it is that they need to promote their own health and well-being in their community. So as I said before, these social determinants of health, they recast health more as a product of society rather than just simply viewing it as being about individual characteristics, attributes, or behaviours. So I've put a reference there where I've drawn some of this material from, and you might be interested to have a look at that more detailed discussion about social determinants of health. So as we move along, I would like you to think about to what extent has there been a national level move away from traditional biomedical concerns towards a more inclusive and society-based approach to health policy. So there are different ways of thinking about health policy as well. In one argument, it can be understood as the financial arrangements that determine who pays for what. Maybe it could also be seen as arguments between powerful interest groups that potentially leave the less powerful without a say. Or perhaps it's also about ideas about what health actually means and therefore what health policy should or shouldn't include. But it does certainly involve who pays and pays for what, and it does signify to what extent health is seen to be a public good. So Alfred identified 3 key groups in Australian health politics, very political space, health policy, I must say. Alfred identified professional monopolists, so they're a dominant group whose interests are served by the existing structures, looking to keep things as they are. And that could include any number of interested parties. One might think of perhaps medical specialists who have a vested interest in their professional arena and wanting to call the shots in the way they provide their services in their specialty, for example. Then we might have what Alfred called the corporate rationalists, and these often might be our health bureaucrats, perhaps even our politicians too, that really bring a focus to rational planning and efficiency. That's what they're all about. And that is much more of a priority for them than just paying deference to the expertise of medical professionals. Of course, they have to listen to them, but what is given priority, it might be a more contested space. And then you have folks that are advocating for equal health and essentially striving for better access to services, often against the long-standing, entrenched structures. So there are lots of health policy actors that Lewis has identified, and there's a list there. It's probably not exhaustive. And of course, you've got governments at state, territory, and federal level, political parties and their different interests, private health insurers, pharmaceutical companies. Some you'll see in the literature, sometimes they're referred to as big pharma, and then a myriad of health service delivery organizations. I've mentioned the health bureaucrats, and of course, the elite of organized medicine and their respective professional associations, and then a whole range of health professionals of different backgrounds and different disciplines, and social workers would come under that category. And then, of course, important in all of this is the service users, you and I and our families, our neighbours, and then, of course, families and carers. I've added their consumer advocates because they are having a much more influential role in health policy arenas. And then you've got various social commentators and the media. So everybody's got something to say about health policy. So just thinking of the background of how health policy has evolved in Australia, in the early days, it was the state and essentially colonial governments that were initially responsible for health policy. Nowadays, the states retain the major responsibility for service provision, including hospitals, much of community and public health and dental services. And they also regulate medical and allied health practices and practitioners, with some exceptions. And Commonwealth and federal government partially funds hospitals, medical services and pharmaceuticals. So it's an interesting mix of funding, and we'll speak more about that as we go through. So drawing again on the Australian Institute of Health and Welfare materials that's in the reference list at the end of the lecture slides, health spending is enormously costly in Australia, and in the year 2020 to 21, it was equivalent to 10.7% of the overall economic activity of our government, federal government, for that period of time. So 220.9 billion spent on health goods and services in Australia. it equates to $8,617 per person. So it's big costs. You may well ask the question whether every person got that much share of the health spending allocation, and I'm sure you'll say, well, it's not the case, but if it were proportioned out to the population, that's the figure that's given. And you can see that this next point there, that during that period, 94.4 billion spent by the federal government, 61.6 billion by state and territory governments. So there's also a big chunk of money that comes from non-government sources. And in the year prior, 2019 to 2020, non-government sources funding was 29.65% of the total health expenditure. So big figures, very costly area. So I think you'd realise that the Australian health system is financed through what you might call a hybrid model, a mix of both welfare state approach and market models, in which the government essentially provides universal public insurance for access to health services. However, and this is where the market model comes in, that it is open to individuals to pay for private health insurance in addition to their public health insurance. Now, how the funding arrangements have come to be organised were articulated in the National Health Reform Agreement of 2011. It's been revisited constantly since that time, but it essentially outlines the shared roles of the Australian federal government and the state and territory governments to work in partnership to improve health outcomes and to ensure that the health system is sustainable. So it does recognise that the states and territories are the managers of the public health system, and the Australian government as having a lead role for delivering general practitioner and primary health care. Now, you might ask, what is primary health care? Primary health is essentially the entry level to the health system. So that may well be the GP. It's often is the GP. Okay, so just briefly to mention that public hospitals, that big and large component of healthcare services, are funded by a combination of funding models. Under that agreement, funding was shifted to what is known as activity-based funding. So hospitals get paid for the number and the mix of patients that they treat. The whole aim is to improve patient access to services and to improve public hospital efficiency, and to provide a more transparent way of funding and ensure greater accountability for how money is spent. So I've got a few questions there that I'd like you to consider in regard to the impact of this policy. So I'm inviting you to consider whether you think that that kind of arrangement might provide an incentive for hospitals to provide high-cost services. Might there be an incentive to discharge patients from hospital at the earliest opportunity? With activity-based funding, a certain cost price is allocated for certain health conditions. So if a hospital takes longer to treat a patient and their length of stay goes beyond what is thought to be acceptable practice, then the hospital bears the cost of that excess amount of time. So you can see that it might be the case that hospitals feel some pressure to discharge patients from hospital as quickly as possible. Now, in one argument, that would be to provide increased access to other people who might be needing access to a hospital bed. Perhaps there are people waiting in the emergency department to be admitted. Maybe people are still on the waiting list for elective surgery, many, many issues. So I want you to think about those issues as we go through some of this content. So another question might be, does this funding model improve equitable access to healthcare? And does it or does it not promote equitable outcomes? Is the system open to gaming the system? Maybe open to cost shifting? For example, if a patient is transferred into the community, then the hospital's not paying for their care anymore. That the cost of their care is shifted to someone else. So there's a fair bit of, I guess, polite negotiation or argument and blaming going on in this contested area of who is responsible to provide healthcare at different stages of a person's experience in the healthcare system. And I always ask, in any policy, we need to consider who might be left behind with this funding approach. In addition, just moving on now, in addition to activity-based funding, there's also additional block funding, which is considered much more appropriate for smaller and rural and regional hospitals, for example. But this block funding also supports teaching, training and research in public hospitals. Very important. Okay, and I've put a reference there for you to look in your own time. The background to hospital funding reform, it gives a lot of detail of the history, but also a comprehensive account of the funding in our health system. So you can see that there's actually a blending or an intermeshing, if you like, of Commonwealth and state activities. And Lewis suggests that it causes considerable confusion about accountability and responsibility, and argues that there is, as I suggested, Lewis argues that there is a significant amount of, my apologies for that jumping in, blame shifting and cost shifting between different levels of government and between health services too, as I said. And I think it probably is fair to say, Lewis makes the comment too, that Labor governments tend to be more supportive of national programs that target help improving access to health services, particularly for people of less financial means compared with perhaps more conservative governments. So you all know about Medicare, and it is essentially our national universal health insurance scheme. And it was introduced in its current form in 1983 by the then Labor government. And so where we're at now with it is that the Commonwealth government collects funds through taxation, including the Medicare levy surcharge that was introduced in 1998, and uses all of that money to finance medical services and public hospital care. And the objective, the main goal of Medicare is to try and ensure equity of access to healthcare. So that's the stated goal. Now, in addition to Medicare, the Private Healthcare of Australia organisation have reported recently that about 55% of the Australian population currently have private health insurance. So then the question becomes, how sustainable is Medicare if so many people are going private, and how sustainable is it too if so many folk have got private insurance? Are they likely to be willing to continue to pay a Medicare level levy, and perhaps they feel put out that their taxes are going to provide services that they're not. Essentially, the argument might be they're not utilising it because they have their private health insurance. So Davey reported in a big study that there was quite an ambivalence in Australians' attitudes to private health insurance. That's very costly, and the premiums are very steep, and it doesn't actually cover anything anyway. And whilst many people have private health insurance, and it did increase between 2022 and 2023, it increased by another 2%. However, we, the rising cost of living and interest rates, steep rental costs, the cost of power, many expenses, it's a great pressure on people as to whether or not they can even be in a position to consider private health insurance. So if it is that we're continuing to rely on Medicare, then there's, and whether or not, I'm going to come to my next, sorry, I was going to speak to you then about bulk billing by GPs, but I'll come back to that. Okay, so I guess there's a question too, whether or not people will be forced to use their private health insurance, because as it currently stands, even with private health insurance, you're not, there's not an obligation on people with private health insurance to use that insurance. If you go into a public hospital, you can opt to. But a question someone with that insurance may well have is, well, will there be any additional costs, any gap payments that might be involved? So there's a lot of debate and argument about that. So there's a lot of pressure on people to utilise their private health insurance if they still come into the public system. And as I say, will these folks still be willing to pay for Medicare and their private health? Now, okay, moving on to bulk billing. So there's been a significant decline in bulk billing in recent years. So by that, I mean that when you go to your GP, that the GP will, your GP consultation would be covered by Medicare if you're fortunate enough to have a Medicare card. If you don't have a Medicare card, absolutely you would be billed for that service. However, many GPs are no longer offering the option of bulk billing. So many people are paying out of pocket costs for healthcare. And this is disproportionately impacting on people without a lot of money. It is arguably a potential deterrent to folks seeking healthcare. And from my experience working in the public hospital system for many years, we know that it has resulted in increased pressure on the public hospital system because people are going to emergency departments for their medical care because they can't afford to be paying the GPs. And the other issue too is that in some places you have a very long wait before you can even get in to see a GP, such is the demand on their services. So even though in the Howard government with the Medicare Plus package, it included some incentives for doctors to bulk bill at least concessional patients, it is the case that GPs exercise, it really is up to their discretion as to whether they provide their service and bulk bill their patients. And I guess from their perspective, they maybe it's the case that the government is not reimbursing the doctors adequately for the care that they're providing, that the Medicare amount is too low, and that they can't run their GP surgeries and clinics for that kind of income. Okay. So there are arguments on both sides. So, and again, it comes back to this issue about whether how we value health services, and perhaps it is seen that access to doctors and hospital services are thought to be a necessity and should be open to everybody, but that many other health services might not be seen as essential health public goods. And of course we can debate that. But, is it about a minimum? They provide the hospital and access to doctors, and that's enough. Never mind if you need a specialist service of some sort or another. So, as I said, we've got a very large percentage of people with private health insurance. And the government really relies on the fact that people are privately insured, and that non-government services are also pitching in to provide healthcare to the population. So in 1996, the government then, a Conservative government, introduced a private health insurance rebate, where if you had private health insurance in your tax return, you would get a significant percentage of that rebated to you under that arrangement. So that was privileging the people who could afford to have private health insurance, I must say. In the same year, no, not in the same year, in 1998, the same government introduced the Medicare levy. So it was, I guess, it was a form of tax, essentially, that those earning over a certain amount would be taxed, this Medicare levy, if you didn't take out private health insurance. So it was thought to be an incentive for people to take out private health insurance, but the argument at the time was that that shift didn't actually occur to the extent that was hoped, and increasingly private health insurance were offering bigger and better deals to entice people to become privately insured. So the way it worked at that time was that if you were younger, you paid less for your private health insurance, and if you were older or left it until you were a bit older, and I don't mean old, I mean, if you left it till you're 40 or so, then you'd be paying a higher premium for your private health insurance. So there were all these incentives going on. So it really represented a shift in favour of people who were wealthy, and Lewis argues that it resulted in a reduction in equity of access to healthcare. And then a Labor government introduced an income test on the private health insurance, so to really phase that out, essentially, and then also took a step to increase the surcharge for high-income earners that didn't have insurance. So why do people take out health insurance? One argument is to receive treatment more quickly. Another argument is that you might have a greater choice of doctor. However, I think it probably is likely, very much the case, that the GP is likely to refer you to a particular specialist of their recommendation or preference. And I think the health insurers may have a say about who you go to or where you receive your treatment. So, we have to question the extent of this so-called choice. And the private insurance might cover a range of other things too, physiotherapy, for example. And other things that might not be covered under Medicare. Okay. So Lewis suggests the argument would be that the complete abolition of that rebate would lower the costs overall, and also might slow the drift of health professionals away from the public system over to the private sector, where they likely get paid better and might not have quite the workloads and workload pressure that they have in the public system. So yes, we can consider that too, about from a perspective of how equitable it all is. And Lewis also suggests that that whole notion of a private health insurance rebate is administratively a big task, and that it's a distortion of incentives and choices and does not meet any reasonable criteria of equity. So just some brief comments about the pharmaceutical benefits scheme. You may well be aware that there is a big list of prescription medicines that the government, the Commonwealth Government, has subsidised in order for them to be available at more affordable prices. So, there are figures there about how much the government does contribute to benefit listed pharmaceuticals. So under that scheme, the patient would be paying, essentially paying a co-payment for listed drugs, but still have to bear the full cost of those drugs that are not listed on the PBS. So in the news within the last week, I saw commentary about a rapid-acting insulin drug used by many type 1 diabetic patients. So type 1 diabetes requires people to use insulin. There's no choice about it. So this rapid-acting insulin drug is going to be removed from the pharmaceutical benefits scheme in 6 months' time. That's how I read it. I hope that that's correct information. And it's going to increase the costs up to, it'll cost something like $230 a month to continue on this particular insulin. So that's the kind of difference the PBS can make to people. And that's a drug in that instance that the patients may well not be able to do without. They would have to be able to get into their doctors. Maybe they have to wait 3-4 weeks for an appointment, maybe longer, to be prescribed something else, and then adjust to all of that if they're to escape the increase of the cost, that is. So I just want you to think about, just in coming to a close of this section of the lecture, to think about gaps in health policy and many of the limitations and challenges. So certainly containing public sector expenditure is a goal. So to what extent is it reasonable to tighten up eligibility requirements? And to what extent is it the people who are not of strong financial means, to what extent is it them that are affected? We need to be aware, and we'll come back to this in part B of this lecture, that people are living longer, often with chronic and complex health conditions. And many people are living longer just brings us to think about our aging population as well, and all the flow-on effects of that. And it might be that at that later stage of life, they're requiring much more, perhaps more complex, more expensive treatments, and arguably more frequent healthcare as well as we age. Another thing to consider too, and we'll come back to this, is about consumers demanding choice and demanding quality in their health services. And that there is, I believe, a strong expectation of people to participate fully in society in order for them to lead what you might consider to be a flourishing life. And of course, we have to think about the health of our Indigenous Australians and the ongoing gaps in life expectancy, and access to healthcare and all the many factors contributing to that. I mention it briefly, not to minimise it, not at all, but just to say we certainly will come back to that in much more detail in, I think it would be in week 7. So that brings me to a close of part B. Thank you for your attention, and I will see you shortly for part B to think about mental health policy, chronic health conditions, and critical social work. Thank you. Bye for now.